to a really hot topic, which is revascularization and unloading in AMI shock, something that's happening around us right now. And to talk about that is Dr. Ishikawa.
Thank you very much. I first want to thank the organizers for having me here today. It's a great pleasure, and I've been spending exciting days learning a lot about shock. So I'm so scared about the time, but hopefully I can finish. I work only on basic research using pigs. So unlike other speakers, my presentation may be a bit different. How do I go next? I may be finished. All right, sorry. Okay, so we've learned in the past yesterday that multi-vessel PCI for AMI shock is not good. So when we have a patient with AMI shock, we just need to treat one vessel and deal with the shock. But even after successful PCI, the coronary flow is still impaired because of these factors. One is decreased cardiac output, which reduces coronary perfusion pressure. The other one is increased diastolic pressure, which compresses the vasculatures, and also lung congestion that leads to hypoxia. So these factors contribute to myocardial ischemia, which worsens the shock. So there is a positive feedback loop between the shock and myocardial ischemia. I think there's a room for the mechanical circulatory devices to break this loop and improve coronary flow in this setting. And let's first look at the forward flow. So this is one of my patients. He got the anterior MI, and he underwent 90 minutes of LAD MI, and then followed by reperfusion for 2 hours. We placed the coronary flow pressure wire in the LAD and put Impella together with LV pressure monitoring. As you see in the right, the orange curve shows the hemodynamics after Impella support. And in the top, you see significant decrease in the LV diastolic pressure. There was also increased coronary pressure, which led to increased coronary driving pressure, which was calculated by coronary pressure minus LV pressure. So this curve correlates very well with the coronary flow, suggesting that LV support increases coronary pressure and improves the flow. I don't think this is limited to Impella because all the devices can improve systemic flow either by increasing or replacing the cardiac output. But we all know that IABP increases coronary diastolic pressure and also the flow. And we also know that IABP does not improve clinical outcomes. So the question is whether newer devices can offer more benefit over IABP. I think they do, and I think the key is the LV diastolic pressure. So in MI, there's increased diastolic pressure because of insufficient pumping function. And this compresses the ischemic wall that prevents flow during the diastole. But by unloading, I think we can improve this flow by reducing the compression on the wall. To prove this, we enrolled more patients and monitored the pressure and volume during LV unloading. As you see, the Impella support reduces both the end diastolic volume and pressure, which leads to significant decrease in the wall stress during the diastole. So instead of measuring the flow with a wire, we used microsphere techniques. So this allows quantitation of flow, and we inject about millions of spheres into the left atrium, which will be mixed with the blood, perfused throughout the body, and they're large enough to get trapped in the myocardium or in any organs in the capillaries. So by taking out the tissue, we can count the number of spheres, and by doing that, we can quantitate the flow. So with this method, we found that LV unloading results in increased infrared perfusion, but not in the border and remote areas. I think this is because in the normal tissues, there are autoregulation that tries to maintain the adequate flow. But in the infrared tissue, this mechanism is disrupted, and the flow becomes more reliant on the external factors. Indeed, when we look at the tissue perfusion in the infrared and the diastolic wall stress, there is a clear relationship indicating the reliance on this wall stress. So recently, we increased the number of animals in this study and tried to identify the factors that can predict infrared flow improvement with the LV unloading. This is a univariate analysis, and the red ones are the significant factors. By using multivariate analysis, we found reduced maximum dPdt and higher end diastolic pressure volume relationship were the significant factors. So this indicates that reduced cardiac contractility and also the heart with that's operating in high diastolic pressure are the ones that benefit most from LV unloading strategies, which are the hearts that are the MI shock in MI shock patients. So this is a study that looked at ECMO versus ECMO plus Impella in shock patients, and we see improved outcome in patients with ECMO and Impella, indicating the importance of LV unloading in cardiogenic shock. So in conclusion, LV unloading in MI improves myocardial perfusion by increasing coronary artery pressure and also by decreasing the LV diastolic wall stress. That said, I don't think there's enough data to prove the clinical benefit yet, so I think there's more need to do research focusing on the flow during the support in MI shock. Thank you very much.
Those are really great clinical experiments. It makes you become a true believer. Dirk, you worked a lot on ECMO. What do you think about what you said?
Thanks. Great talk. I really enjoyed it. Really focusing on the hemodynamics, right? And I think the one part that is also true for our patients, and we spoke yesterday about DTU and stuff, is that really reducing end-diastolic pressure. That's probably the key of all of it, because it increases perfusion, and that's actually what we want to do. And from a clinical perspective, you can easily see that when in the last angio, you are just going, and you have a good flow, as a clinician, you know that LV-EDP is relatively low. And if it's really very high, you can really see that the coronary flow is low. And I think that's something that you elaborate very nice.
Anybody else?
So I have a question. I think your first animal, or the first subject that you talked about, the hemodynamics were very interesting. The coronary flow was increased, the driving pressure was increased, more coronary flow, and then between the coronary and LV. But we're all obviously, a lot of us are participating in the DTU trial. We're anticipating for the data to come out hopefully very shortly. But based on what you're seeing over here, did you emulate what you're doing in DTU with that? Were you guys ever planning, or have you done anything so far where you have done unloading first and waited 30 minutes and seen what happens to the driving pressure in that scenario versus the regular way? Would that help us understand what we have to expect in the future maybe with STEMI DTU?
Yeah, I think that's a good question. My data now is talking about post-reperfusion, but I think the same mechanism can be true for the acute MI with occlusion. With reduced wall stress, there may be more increased collaterals to the ischemic area. And it's going to work, but in pigs, there's less collaterals. So we need to have more good models and to understand how wall stress contributes to the coronary flow, both in the clinical and preclinical areas.
Yeah, I was gonna make a point regarding what Dirk just said about pressure unloading. And Jeff, you may have not been here yesterday, but Dr. Boscourt, Bickham make a great point about and I don't know if it was just a theoretical question she had about transmural pressure reduction. So remember, these patients are breathing hard. They should be if their LVDP is up. So, and then Dr. Mooney yesterday and I were discussing that, well, how low should the LVDP be? Because it gets into the question of, if you look at someone after ECMO support, sometimes, I mean, again, we should really measure this, but some of these LVDPs after ECMO support in acute MI, not acute and chronic shock, but acute MI, they're probably pretty low based on my heart failure low-high. So the question is, do you think it matters even at the level of a small increment in EDP reduction? Or do you think there's a different thing that we're not looking at as far as diastolic some kind of unloading that doesn't relate to pressure?
So if I just can start, I guess actually the acute changes are important. So even smaller changes, but when they come very acute in army, might have an impact.
Okay.
And I guess, so that's actually my guess, that the autoregulation mechanism in chronic heart failure take care of that, at least to some extent. And that's the same like when you have a tamponade or something, right? Very small blood is detrimental if it comes in acutely, but there's autoregulation in hemodynamics, and there's a lot of autoregulation in hemodynamics. That could at least be one part of it.
There's a question from the audience.
So post-reperfusion, how much is the ischemia reperfusion injury not helping to this? And if there is any data that you have on preconditioning, like patients that come with collateral flow already? Because we already know that old people sometimes do better than a young patient that is coming in acute MI because they have some preconditioning. And that also will help with the diastology on these patients. All of us know ischemia, the first problem is diastology. So I think that will be a very interesting question to do. We have been dealing with ischemia reperfusion for a long time. That's part of the problem, that's part of the diastology issue on those patients. So it will be interesting to know what happens when you have that part and when you don't have it. Do you have any information or any on that?
So
Ischemia reperfusion and preconditioning for ischemia. Like if you have collaterals and you have an acute MI shock, is that different in terms of diastology and post-reperfusion improvement or not?
Do you mean the role of preconditioning in this
Yes.
situation?
Yes.
In these animal models, if we do preconditioning, they have so much reduction in infarct size, so we try not to do anything like that, and we pay very careful attention. But I think preconditioning is a really strong effect that we see in animals, and probably in humans too. The effect of unloading on preconditioning, I don't have any data, and will be something we can explore.
So let me ask anyone in the audience to chip in. We've spent 20 years understanding bleeding risk and trying to reduce bleeding risk and going radial and doing everything because you're concerned about bleeding. Do we think that the benefits of this, extrapolating large bore devices in this setting, how that bleeding risk and this new physiology is going to balance out? Or are we opening Pandora's box?
I think it speaks to the challenge of designing these trials, and particularly the endpoints. Again, what are clinically meaningful endpoints for these trials? Do we truly expect in an AMI cardiogenic shock population, which we've already acknowledged, at least in North America, tends to be a smaller proportion of our cardiogenic shock patients, do we really anticipate that we're going to see a demonstrable improvement in short-term mortality or intermediate-term mortality? Should we be looking at both safety and primary efficacy endpoints like bleeding, because we know that that's not benign. So, I was going to ask a very similar question. What do you think are really meaningful endpoints for these trials?
Yeah, it's a good question. I think it's easy in animals because we can quantitate flow,
right.
But in clinical condition, it's really hard. MRI, we can't take in unstable patients, and there's no way to quantify the flow. So, the flow wire is one option, but it's only instantaneous flow. And there's a really need for new measurements to non-invasively measure cardiac perfusion or tissue flow and how to correlate it to the clinical outcomes. So if we can, maybe using echo with microbubbles, try to quantitate the flow, that might be helpful. But I think the endpoint should be the hard point, with maybe trying to correlate with the coronary flow with different parameters.
One last question, we're coming to the end, so just be brief and brief answer, please.
Yeah, I just needed to know the duration of unloading because it's important after an AMI shock. Say you have a patient in the cath lab, LVEDP is 20. You put an Impella, whatever Impella device you put in. How long do you unload?
We unloaded 2 hours.
But the reperfusion injury goes on for 12, 24 hours. So if you take the Impella out, there's going to be further damage. So what is the utility of putting a device and taking it out in 2 hours?
Right, it's important.
That was a great talk.
That's a great talk.
Thank you so much.